Good morning, ladies and gentlemen. Our first speaker is Dr. JAINY, who shall be speaking on the disc dilemmas. And Dr. JAINY is a consultant at Amala Eye Hospital and an alumni of Thrissur Medical College. Over to Dr. JAINY.
Okay, so it is actually an easier situation when the intraocular pressure is raised. It is easier to diagnose glaucoma. But the disc dilemmas mainly arise when there are the optic disc and the visual field changes, but still the IOP is normal. We are confused whether is this a glaucoma patient or not. So the examiner has to rely on the appearance of the optic disc mainly to assess the glaucoma and diagnosis and the progression. So why is the optic disc evaluation very important? Because the optic disc and the RNFL changes is the first which occur and the visual field usually occurs later. The intraocular pressure and the visual field lacks the diagnostic sensitivity and 20% of the non-glaucomatous discs are treated as glaucoma. So we should be aware of the typical glaucomatous features and the non-glaucomatous features. So is this disc glaucomatous? If I ask you the question at this point of time, still we are again in a confused state. So we'll come to this question at the end of the session. So what are the typical glaucomatous disc changes? We'll just go through it through the typical changes. So main thing is that we should look the disc size. The size is usually you should correlate the size of the cup with the disc. And regarding the cup, we should be noting the shape of the cup and the size of the cup, which is correlated to the disc size, and the thinning of the neuroretinal rim, notching, vascular changes, and the hemorrhages on the disc. As I told you, usually glaucoma is overdiagnosed in larger disc, and the smaller discs are actually more susceptible to glaucoma, which is usually missed. So the disc size should be always measured and the cup should be related with the disc. And as I told you, how to identify the cup margins is very important because it's usually normally the cup is horizontally oval. So you should see where the vessel is bending. So here we can see this is the area of the vessel bending there, which gives us the limits and the margins of the cup. And the cup asymmetry between the two eyes, if it's more than 0.2, is more suggestive of glaucoma. Then comes the neuroretinal rim. As I told you, it's the thinnest neuroretinal rim should be identified, and the extent of the lost NRR, particularly the color and the focal notching, is very important in interpreting glaucomatous disc. Then comes the vascular changes. I told you the bending of the vessel is very important because it helps us in the contour cupping. You should find out the cup by the contour change of the blood vessels rather than the color cupping. Then the presence of disc hemorrhage is usually suggestive of glaucomatous progression of glaucoma and is more commonly associated with normal tension glaucoma. And the peripapillary changes, the beta zone atrophy, more suggestive of progression of glaucoma, and the typical RNFL defects which occur in the superior and the inferior area of the disc, which is more seen in a red-free setting. So these are the routine glaucomatous typical changes of glaucoma. So what is the disc mimickers and why are those mimicking glaucoma? The main thing is that either the cup disc ratio is very more or there will be a cup asymmetry will be there usually, and whether it's cup or whether it's pallor, we are still again confused. And the same hemorrhages, RNFL defects, visual field defects, all can be seen also in other conditions which may mimic glaucoma. So it's very important to differentiate each condition. So what are our optic disc mimickers? We have few congenital conditions which mimic glaucoma and few acquired conditions. We'll go into each condition. First, the congenital disc mimickers. One is the primary macro disc. This is the megalopapillae. Usually the disc is usually very big, usually bilateral from birth, asymptomatic. There's no any functional loss. The cup will be very big within an IC32 rule, violated. So these are actually primary macro discs which are not glaucomatous. Then this condition, optic disc coloboma, usually if we properly examining the disc, even though the pallor mimics some cupping and all, actually the excavation is seen inside the disc more inferiorly. And it can be associated with this retinal choroidal colobomas and associated visual field defects, very dense defects can be seen also in optic disc colobomas. Then the morning glory syndrome with more typical features, a unilateral middle-aged female comes with a particular appearance like this, where the disc lies within the excavation and the blood vessels are emanating from the central tuft, glial tuft, which can mimic similar visual field defects. And the optic disc pit, when we visualize the disc very clearly, we can see there's a small depression usually in the inferior inferotemporal area of the disc, which can be associated with serous macular detachment. Another particular condition is a superior segmental optic nerve hypoplasia, where we'll see only the superior disc pallor will be there with corresponding an inferior arcuate defect. Is usually associated with uncontrolled gestational diabetes babies born with GDM or with low birth weight babies. And the most confusing condition is the myopic disc. It's always confusing due to the shallow, large cups, tilted disc, oblique entry, and Dr. Jason will be enlightening this in the next session. So these are the congenital conditions, and what are the acquired conditions which are mimicking glaucoma? The most common mimicking conditions are traumatic causes, demyelinating causes, ischemic optic neuropathies, toxic causes, and the compressive optic neuropathy, which can mimic glaucoma. So why is this mimicking? Mainly it's due to we think it's something pallor or some cupping and all, but actually what is the most prominent feature in these conditions? It's mainly the pallor. This pallor which is more than cupping. When we examine the disc, we will see that the cup is very shallow and the pallor is more prominent. So we should not miss these conditions can be traumatic and toxic compressive lesions. The other important feature to differentiate it is that the age of the patient is usually a young patient and the presence with early visual loss with RAPD, color vision problems, and the visual field defects will follow the vertical meridian. And usually these conditions, even though mostly are unilateral, it can be bilateral in case of hereditary cases and nutritional cases. And the RNFL thinning, mainly it is seen in the temporal RNFL thinning, which is more prominent in non-glaucomatous condition than the typical superior and inferior thinning in glaucomatous patients. So those points are important to differentiate both. So the retinal nerve fiber defects also is similarly seen in the ischemic causes, toxic, demyelinating causes also. We'll see the retinal nerve fiber layer defects which can mimic glaucoma. The retinal conditions also can mimic glaucoma. Due to this, the vascular occlusion is a very, even the glaucoma is a risk factor vascular occlusion. We should see the peripapillary retina for any perivascular sheathing, sclerosed vessels, new vessels, focal attenuation, RP degenerations to rule out this glaucoma. Neuro-ophthalmological conditions, as we already discussed, the chiasmal and the pre-chiasmal tumors can mimic glaucoma, but the pallor will be more than cupping, and there comes the importance of our Greenfield criteria, while we assess the age, visual acuity, RAPD, and the vertical field defects. Inflammatory conditions, even though in acute stage, it will not confuse us, but later when the patient comes with temporal pallor, it may confuse as glaucoma, but the subnormal color vision, visual acuity problems, and the central scotoma will help us to differentiate those conditions. Hereditary cases also can present with bilateral temporal pallor centrocecal scotomas, but the family history of poor vision, associated diabetes mellitus, sequential loss in Leber's hereditary optic neuropathy and all will help us find out the differentiation, and then in those cases there will be the temporal loss of RFL will be more prominent. So the take-home message is optic disc evaluation is the heart of glaucoma management, but still we cannot depend on the disc fully, and the entire clinical picture should be taken into the consideration. So this patient now, is this glaucomatous? Here it is a middle-aged female, large disc, large cup, normal visual acuity, visual fields are normal, and now it is not glaucoma. Thank you for your patient listening.
Thank you, Dr. Jaini. That presentation was very good and you helped us to elucidate a lot of dilemmas regarding the